Ladies and gentlemen, now it's exactly 3 p.m. and we will start with our lecture on radiology of the upper GI tract. I am Peter Pokieser, radiologist, and Martina Scharitzer and Doris-Maria Denk Linnert, ENT, will make together with us a case-oriented lecture on radiology of the upper GI tract. This will contain a lecture which will be about 40 minutes, and then we will provide you a quiz which will give you the opportunity to win book prizes and to test directly your diagnostic abilities. Most of them you may have got in this lecture, and this is just a slide which should give a short introduction. Our purpose is to learn about the strengths and weaknesses of dynamic radiology of the upper GI tract by case discussions. As you know, in former times we had some efforts to diagnose morphology of the upper GI tract, and endoscopy in the last 20 years took over the most of indications to evaluate directly the morphology of the upper GI tract as well. ENT did it for the throat, and gastroenterology and surgery for the esophagus and stomach. But nevertheless, we do have indications for upper GI radiology, for the pharyngeal case, to study dynamically aspiration, to see motility disorders of the esophagus, as well to see morphology which is best seen in dynamic action, like diverticular or achalasia and postoperative cases. By that, we would like to change now into the dynamic part, and the most important part of this. You can see now is our app on dynamic imaging of swallowing. And the left upper quarter of this screen shows us a dynamic swallowing of the oropharyngeal stage, and on the right of it, in colors, you see the 7 functional units of dynamic imaging of swallowing. So the yellow arrow indicates directly on the first unit, which is the tongue. The light green one indicates the soft palate, the dark blue one, the action of the epiglottis, the light blue one, the motion of the hyoid and the larynx, the orange one, the Pharyngeal Constructions, the red one, the upper GI sphincter, the upper pharyngeal esophageal segment, and the white one, the esophagus. When we go back now, this investigation is done for patients suffering from dysphagia or global symptom or non-cardiac chest pain, and just in a short moment look at the setting of the investigation. It's just a simple fluoroscopic unit, and what we do is filming the patient in the erect and in the horizontal position. So let us go now to the first case. The first functional unit we should discuss is the tongue. And when you see the movement of the tongue indicated by the yellow arrow, you see a perfect motion of the tongue, pressing the bolus against the hard palate, and then propelling the bolus directly into the pharynx, where the involuntary swallow is elicited. So let's see a patient with pathology. This old lady has got barium, which is a contrast material which is neutral for swallows and can be aspirated in small portions, but to investigate oropharyngeal stage, often we mix it with red. In this investigation, you see this patient swallowing. The bread is manipulated on the tongue, on the back of the tongue. You see violet arrows on the hard palate. And now the pharyngeal swallow. So what we would like to do is we would like to open the chat now for you. If there is anything you could see pathological in this swallow. The tongue should clean the mouth and completely swallow the material and transport it into the pharynx. As well, there should be a clean pharynx after the swallow as well. Within the chat, is there any idea? What's pathological in this motion? Question to the audience. Is there anything left in the oral cavity, or do you think that the material is propelled completely into the pharynx?
There is a question coming in which says stenosis of the esophagus.
Well, the esophagus is seen in this setting quite short. A short segment of the cervical esophagus is seen, and the contrast material running through shows only a little opening of the upper sphincter. But the pathology we are looking for is much more above. Firstly, what we can see is that the tongue is not clean after the swallow. After swallowing, contrast material sticks to the hard palate, as you can see with the white arrow. And then in the pharynx you see an area with a violet circle, and there pharyngeal retentions are present.
Another idea is that there is not enough pressure due to a weakness of the tongue.
Exactly.
And another comment was that there might be some contrast medium in the trachea.
Perfect. So this is true, and this is a very important finding in this case. The tongue is not only responsible to propel the bolus backward, as well it's responsible to give force to the involuntary swallow. And this is a very good idea in the audience to speak about the weakness of the tongue. The weakness of the tongue is reflected by two pathologic findings we see on the screen. Firstly, the pink or dark or violet arrows indicating the hard palate show that there is contrast material sticking on the hard palate. So this indicates a weak tongue. As well, we do have retentions in the pharynx, and they might be due to weakness of the tongue and the pharyngeal constrictors. So I would like to ask Doma Denk, do you think, Doma, that you can differentiate between the weakness of the tongue and the pharynx, or do you think this is a continuous problem?
Mainly these two entities may be present together, but of course in the clinical exam you can test the strength of the tongue, and of course you see it during endoscopy also if the pharyngeal peristalsis does not work properly. But in case of neurodenic dysphagia, for instance, you see often these two pathologies in combination.
And secondly, there was a participant telling us that there was aspiration. Do you have any idea when the aspiration took place? Is this an aspiration during or after the swallow? I would be very interesting what the people in the chat might answer on this.
coming in at the moment. In the meantime, oh, there is. Okay, there's one colleague who says during and another one who says after.
Both of them make a good suggestion. In this case, because of the retention, the big potential of aspiration is mainly after the swallowing, as a post-deglutitive aspiration. But of course, because of the weakness, as well as the laryngeal closure, there might be some penetration in the interdeglutitive phase as well. But this is a case of post-deglutitive aspiration because of pharyngeal retentions. Martina, do you think that we should comment on this case? Anything more?
Well, you could mention that the degree of pharyngeal retention is a predictive factor for aspiration, mainly for post-deglutitive aspiration. So if you have a lot of pharyngeal retentions, then the patient is at risk for aspiration. And of course, you could then also test different consistencies, because if the patient does not swallow liquid consistencies but thicker consistencies, then aspiration can be prevented.
Okay.
Of course, there has to be enough pharyngeal strength to swallow the thicker consistency, which is probably difficult if the patient has marked pharyngeal weakness and weakness of the tongue in combination. It's very difficult to find the appropriate consistency, or you can try to reduce the bolus volume. Perhaps this might have a positive effect on aspiration.
So we have one question left from the audience. If we see the reticulum ventral things happening.
No, this bulging you might judge as a reticulum are the valleculae. I think that the participant was thinking about that. And this is just an outsparing on the root, between the root of the epiglottis and the tongue base. And this is one of the classical two parts of the pharynx where retentions might be visualized. These are the valleculae from the lateral projection, and down here the hypopharynx. The contrast material I'm indicating now, this is due to contrast material within the larynx, and parts of it aspirated in the trachea. So I would say we go over to the next case. Well, this is a nice overview of the lateral pharynx, and this is a good case showing again the anatomy. We see here the valleculae, the space between the epiglottis and the tongue base. Here, a little bit contrast material is collected, and down here we have the hypopharynx, the sinus piriformis, the piriform sinus are divided into two by the larynx, but this you can see only in the frontal projection. And here we can see the soft palate from the side on this X-ray, and the soft palate has two duties. One is to seal the oral cavity against leaking from material into the pharynx, and during swallowing, the soft palate seals the nasopharynx to prevent nasal regurgitation. So let's have a look on this patient. This is a post-operative situation, and we see many pathologic findings, and they are for your convenience marked with arrows. And this is the swallow. So some of the findings you might know from the former case, but there are some new findings. So is there something in the chat?
No, not yet. To go too fast for that.
Yes, we give you time. So this is barium in the oral cavity, and then the swallow starts. we have two suggestions. One is regurgitation and the other one is aspiration. We do have some drops of aspiration, but at the large it is a penetration into the larynx, but this is a good observation. We see with the dark blue arrow, we see the epiglottis, and with the light blue arrow, we see penetrated contrast material within the larynx. And the regurgitation was correctly indicated by the participant 2. The green arrow is indicating the soft palate, and now the pink or violet arrow shows nasal regurgitation. And the soft palate is differing in the contour. Here on the left, we see somewhat bulged form, and on the right, this is the normal soft palate. So this is a post-operative situation after resection of a carcinoma. And at this functional stage, we have nasal regurgitation because of the defect of the soft palate. And as well, we have a pharyngeal problem. So we have a penetration into the larynx, and some drops are below the vocal cord. So, is there any finding which is similar to the last case in the pharynx?
There's two suggestions coming in. They both say fistula.
Okay.
Not compared to the last case, but
yeah, that what is comparable to the last case are the pharyngeal retentions in the vallecula, and not that much in the hypopharynx. So from the contrast material after the swallow, which is coming down the pharynx, it looks like retentions, but most of them are in the vallecula. We do not have a fistula in this case, only the nasal regurgitation. Toma, which would be your therapeutic approach?
First, we have to do an inspection of the velum, also from the video endoscopic point of view, in order to really find out whether there is an incompetent velopharyngeal closure and the degree of this incompetence. So if it's possible to compensate, then we will make a logopedic therapy with the patient. And if the defect is too large that we cannot really achieve a better velopharyngeal closure, then perhaps some prosthetic therapy may be discussed.
Okay, so I would say that we go over to the next case. So we have 7 functional units, as you can see on the left of our app design, and we will move over from the soft palate now to the epiglottis. Toma, would you say that somebody can live without an epiglottis?
Indeed, it is possible, because the epiglottis is one level of the laryngeal closure during swallowing, but there are other levels of pharyngeal closure, so the patient can be trained to swallow also without the epiglottis. We see this in patients with carcinoma after resection of the epiglottis, and mainly they have to get some training in order to get used to the new situation, the new anatomy after resection, but they can learn indeed without aspiration.
Okay, so that means the epiglottis helps us to prevent the larynx, let's say, against rough consistencies.
Yes, and the other levels have to really work more if the epiglottic is not anymore present. So this is, of course, some therapy necessary to learn.
And in this patient, which is a 74-year-old man, and is suffering from morbus Parkinson. And what is the pathology we can see around the epiglottis? The light blue arrows are indicating the movement of the larynx and the hyoid. Martina, do you think that this is a correct movement of the larynx and the hyoid?
Well, you can see a distinct approach to the mandible, which is normal. And if the larynx is elevating in a good way, then it's also a good task for prevention of aspiration.
So at last, what we see is a normal movement of the almost a normal movement of larynx and hyoid. Maybe the approach from the larynx to the hyoid bone might be not optimal, but at large it's a normal movement. And this is very important to open the upper esophageal sphincter, as you can see with the white arrow. So there are no retentions after the swallow, but the pathology of the epiglottis is what? Is there any suggestion in the chat?
Not at the moment.
So the epiglottis is lacking of what? What do we miss?
Tilting.
Well, in this case, the pathologic finding is quite easy. The epiglottis doesn't tilt correctly. I will show you the normal movement of the epiglottis would be that it is tilting completely. So that you see the epiglottis exactly where the blue arrow is. I support this with another white arrow. This is the epiglottis during the passage, which is tilting completely. And then you can see nicely the tilt when the epiglottis is going back to the restitution. So the normal epiglottis tilts better seen in action than on the images. And in our case, we just have shown you before, morbus Parkinson, this is a lack of tilting, and this is leading to retentions as well. So this is sometimes the only sign of neuromuscular impairment of the pharyngeal passage, and can be seen as well in patients after stroke. And it's maybe important to say that 8% of our patients are presenting with pathologic findings of the pharynx and the esophagus as well. So radiology has the opportunity to show both levels. This is very important in diagnostic cases. Doma, could you explain us the difference between diagnostic and therapeutic cases?
Well, of course, in many cases there is a combined approach. First of all, we would like to know the pathology of the patient. The focus of our diagnostic interest is, of course, aspiration. If aspiration is present, we want to classify if it is before, during, or after the swallow. And within this diagnostic procedure, the therapeutic approach includes that we try strategies to reduce aspiration. That means that we try maneuvers, tilting of the head or chin down position, or we try to modify the texture of the bolus in order to be sure that, for instance, a more pureed bolus helps to reduce aspiration, for instance, in patients who have reduced swallowing reflex. So this is a very important step in order to be able to really find a therapy regimen, what can be useful for the patient. And this is the diagnostic offers in video endoscopy and also in video fluoroscopy, so that we know what is useful for the patient.
So thank you. This is a very important differentiation for the radiologist whether to be alone with the patient to make a proper diagnosis or to be in the team with the therapeutic approach, just to seek for the right way to swallow. So let us go to the next functional units, and this next functional unit is the larynx. So let us have a look at the normal patient. In a normal patient, you see a very wide and large movement of the larynx and the hyoid bone. The upper arrow, the upper light blue arrow, represents the hyoid bone from the lateral view, and the lower light blue arrow represents the movement of the larynx. And you see a band of air, and this is the trachea. And the upper limit of the trachea are the true vocal cords, and they are represented as a level by the lower light blue arrow. And this is a very important observation. The movement of the larynx and the hyoid bone allows the upper esophageal sphincter to open. It is not only that the resting pressure is decreasing during the involuntary swallow, it is very important that we have this movement, this upward movement of the larynx. Otherwise, retention would occur, as you have seen in the first two cases. So, now we have another patient with a neuromuscular disorder, and we would like to know from you the mechanism of aspiration. When do you think the aspiration does occur? Could you describe that in the chat? You see the tongue, and the contrast material is flowing over the tongue. And I would like to hear from the colleagues in the chat how the mechanism of aspiration is here. It is different to the first patient. A 2-year-old male patient with a history of stroke and has problems with drinking.
Be aware of the swallow reflex.
The pink arrow is indicating aspiration, and during drinking, the contrast material just rinses over the back of the tongue and is the aspiration. Now, during the swallow or after the swallow or at any other stage.
No comments yet. Next one. Okay, after.
So let's have a look. Now the upper sphincter is closed, so the involuntary swallow did not start yet. And now we have already aspiration, and now the involuntary swallow starts. Exactly at this moment, where we can observe an opening of the upper esophageal sphincter, and the patient already has aspirated. So the time point of aspiration is not after, is not during, it is before involuntary swallow. So this is a pre-deglutitive aspiration, as you can read it in the headings. And this is a dissociation between the laryngeal closing and the passage of the involuntary swallow. Thomas, do you think that this is an important therapeutic observation, and how do you work with the patients?
It is indeed, because the swallowing reflex is not elicited properly, so the contrast material pours down and causes aspiration before the swallow. So what is important, you can of course work on the triggering of the swallowing reflex with eye stimulation. And in this case, one would also try to change the head position with a chin down position, chin tuck position. And so you see that the patient really bends back the head, and so the material pours down into the pharynx, and could perhaps be prevented if the patient has a chin down position. He needs specially designed glasses in order to be able to have this chin down position also during drinking. And you can try also to change the bolus consistency. Perhaps more purate food, more purate liquids can help to really reduce aspiration.
Okay. And here we have an example of an intradeglutitive aspiration. Martina, would you like to explain this for us?
Well, in this case, you can see that the bolus reaching the pharynx is divided, and a large amount of the bolus is misdirected into the trachea because laryngeal closure has not been completed, and so it's a kind of intradeglutitive aspiration. And of course, you need a higher frame rate to be able to differentiate these different forms. You won't see it with a normal swallowing investigation with 1 or 2 frames per second.
And there we can observe any cough reflex. I think the patient doesn't react. This is also a very important point from the clinical aspect.
Yeah, it's very important if we do observe coughing during the investigation or not.
We would call it silent aspiration.
Yes, that's silent aspiration if no cough reflex occurs.
Did the patient we saw before cough during the aspiration?
No. Also, the patient before did not cough as well. Okay.
So silent aspiration is a very heavy problem because the patient and also this observing other family members or whatever don't really realize that there is aspiration present.
So to sum up the time points of aspiration, we already have seen aspiration before the swallow, which is pre-deglutitive. This patient during the swallow, which is intradeglutitive, and as well we had seen aspiration after the swallow. So we will show you here in another neuromuscular example a very indicative post-deglutitive aspiration. And maybe Martina, you would like to explain us the mechanism here?
In this case, you don't see the investigation lateral position, but you see it in the frontal position. And you can see that in the middle there is this line produced by contrast media, which means there is penetration followed by aspiration if the contrast media is below the level of the vocal cords. And now you see this line, and the swallowing has already been finished, the swallowing of the bolus, but there are retentions within the pharynx, and out of these retentions you can see this post-deglutitive aspiration starting after the swallow.
Okay. What we can see here, there is a white, completely round lucency, and this is the impression of the larynx against the dorsal wall of the pharynx, and this is dividing the transmission of the bolus over the sphincter in 2 pathways, and this is a sign of weakness, which is very classical in this case. So this is pharyngeal weakness with retentions, and now you see the aspiration after the swallow exactly in the midline. So we have had all the different types of aspiration. Just in an overview, of course, we could differentiate that a little bit more. But now we will go to the 5th functional unit, and this is the pharyngeal constrictions. So what's the normal function in this setting? The normal function is now seen in the frontal projection The normal function is a complete clearing of the pharynx after the swallow and a movement from the lateral walls to the midline. So, Toma, you said that pharyngeal weakness you can see perfectly in the endoscopic evaluation.
No, not. This is the problem. One can make the pharyngeal squeeze test that you can ask the patient to phonate very in high tones and really to imitate suffocation, and then you can see what the pharyngeal muscles do, but it's sometimes very difficult to decide, and we have often only the indirect signs of pharyngeal weakness, that we see pharyngeal residue. So we don't see this constricting movement, what you can more properly see on video fluoroscopy.
And here we see an elder lady with dermatomyositis. So we have a disease with muscular weakness. And what we have here is retentions in the vallecula and in the hypopharynx. So again, like in some other patients we have already seen, this is a typical sign of pharyngeal weakness, and the orange arrows are indicating the retentions, and the yellow arrow is indicating the back of the tongue, and the back of the tongue does not reach the pharyngeal wall, the dorsal pharyngeal wall perfectly, and this is leading to these retentions. So now we have to see something very important, and as you can read the diagnosis as well, we would like to know from the audience, do you have any suggestion why this diverticulum of the pharyngoesophageal segment is causing dysphagia? Is there any idea? The pink arrow is indicating the diverticulum, the Zenker's diverticulum. The red arrow is indicating the pharyngoesophageal pathway, and the white arrow is indicating the esophagus. What does the diverticulum do to the patient? Is there any suggestion in the chat? How does the mechanism work for a Zenker's diverticulum?
There's a suggestion coming that the reticulum takes up the fluids and the bolus and then remaining in there.
That's true. And the filling of the diverticulum causes which problem to the pathway of the food? By filling, the next step after filling is, and this is the take-home point here. Martina, maybe you could explain that to the colleagues?
As you can see, this diverticulum is quite large, and so it produces an impression on the real esophageal lumen. So more of the bolus will be directed into the diverticulum, and the patient has problems, especially for thicker or solid consistencies, to bring them into the real esophageal lumen. And this is the cause for dysphagia.
So it is very important for you to take home for general medicine that even if a Zenker's diverticulum may be only 2 to 3 centimeters big, it may cause severe dysphagia by pressure on the pharyngoesophageal segment, which is shown in this case, and this is not bigger than 3 centimeters, this diverticulum, but is leading to a severe obstruction. And often in my routine, I see patients, they are judged to have a harmless, so-called harmless diverticulum, but in the functional radiologic test, we can prove that operation is indicated, strongly indicated, like in this case. So, let's move on to something different. Is there somebody who could describe the mechanism in this case?
Congestion stenosis.
Not wrong, it's true. But what is the reason for the stenosis? Any idea?
Yes, it's spondylosis.
Okay. And this is true, we can say. It is severe spondylosis, and we have a spondylophytic growing, which is on the anterior alignment of the spine, of the cervical spine. And this is exactly at the entrance of the larynx.
Might also be an abscess.
Well, if there is a spondylophytic growth like here, then there is not too much space left for an abscess, but this is a good suggestion because in patients who have a widening of the retropharyngeal space, they might have an retropharyngeal abscess. There is the question back in the chat, which would be a good method to investigate for a retropharyngeal abscess. This is not video fluoroscopy or plain radiology, which would, yes, it's very good. And another option for those who cannot afford an MRI? Well, CT is perfect as well to look for inflammatory problems of the pharynx. But in this case, it's a huge spondylophyte. And Martina, can you explain us how much do you see in your experience cases with spondylosis who are leading to swallowing problems?
Well, I see several cases of spondylosis, but normally patients are used to it and they get problems if they have an additional neurological problem. So they have kind of pharyngeal weakness or delayed triggering, and then aspiration or severe retentions occur, and then the patients come to hospital.
The compensatory capability of the swallow in these patients is very small.
Yeah.
So they are on the edge of decompensation. It works, but if some pathology comes in addition, the system breaks down.
That means a patient can compensate that for a very long time.
That's right, because it develops slowly. Of course, if there is some degree where there is a heavy stenosis, and of course this is also a limitation. But if some a really cerebrovascular accident, for instance, even a very small one, is present together with this dish, with this diffuse idiopathic skeletal hyperostosis, then the patient really has heavy problems, and sometimes the neurologist does not really understand why the swallowing problem is so heavy, but in combination with such a spondylosis, one can understand.
Yeah. So important for you to know, it is a very difficult indication to send a patient for operation of spondylophytes, and only really careful centers who have a lot of experience with swallowing problems should decide on that. You agree?
Yes, that's right.
It needs a lot of experience because most of the cases can be handled conservatively, and only very rare cases can be handled with operation. So I would say in a 2,000 a house with 2,000 beds, like the University Hospital in Vienna, we may have one a year
For operation
of a spondyloarthritis.
Yes, 1 or 2 a year.
And we have thousands of patients coming with swallowing disorders.
That's right. So it's
so it is rare.
Rare, yes.
Indication to operate on that is rare. And Martina, this is your patient. Was operated?
This patient was, I think, he was not operated after investigation because they had to check further problems. It was not his only problem.
Yes. And you contributed to relieving from that operation through this study, I think. So this is an important thing. So we now move on to the 6th functional unit, and this is the upper esophageal sphincter. So let us discuss firstly this case. So what we see here is a patient with a very bad neurologic disorder, and we see retentions. And additionally, I would like to hear from the chat, what are these 2 pink arrows indicating? The white arrow is indicating the esophagus, the orange arrow is indicating the pharynx, and the 2 pink arrows are indicating which part of the swallow, which pathology they are indicating.
The audience is still thinking.
Yeah. So what we see is a dynamic movement between the pharynx and the esophagus of 2 structures. And what do they show? What do they represent? Let's start with the swallow, start of the involuntary swallow, and only small amounts of contrast material reach the esophagus.
So there's a comment that it's dyskinesia.
Yes.
And another question is if you could see varicositas of the esophagus like this.
This is a very interesting idea, but at the level of the pharyngoesophageal segment, we would not see enlarged venous structures. They are seen much more caudally in the tubular esophagus. And what we see here that was a correct statement. This is only dyskinesia of the upper esophageal sphincter. And we see a very strong obstructing muscular problem, and the upper sphincter does not open at all. And in this case, these bars are leading to an almost complete obstruction, and only small amounts of contrast material are entering the esophagus. And this patient was a 78-year female patient with muscular dystrophy. So the question now to Doma Denk, in such an obstruction of the entrance of the esophagus, do you think that myotomy could help?
First, I would try the injection of botulinum toxin in order to find out whether this really weakness of the upper pharyngeal sphincter helps, because there has to be some pharyngeal pressure to be reached so that myotomy or surgical measurement on this pharyngeal esophageal sphincter really have success. If the patient, I remember some patients who are not free for general anesthesia because they are so old and they are multimorbid, then one can also try functional logopedic therapy, for instance, the training of the esophageal sphincter, Mendelssohn maneuver, Shakir maneuver, I remember a patient after a severe head trauma, and he could not be operated on, and he really trained very hardly, and he was successful in really reaching a reopening, a functional reopening of the upper esophageal sphincter.
Okay. So again, we have a condition where it is extremely useful to involve an experienced center. So we will go now to another mechanism of swallowing problem. And we see here the pharyngoesophageal segment. And the special condition, I would like the audience to describe this kind of condition. Is there anyone who can describe the mechanism at the level of the upper esophageal sphincter? There are two different patients. One patient showing this condition in a low grade, this is on the right, and in a severe grade on the left. And what's happening here? Is this normal? No.
Okay, there's stenosis.
Yes. And what could be the reason for this stenosis? There are many reasons for leading to stenosis, but what could be the case here? And in the right, we have it in a typical presentation, and on the left in a severe version. These are just membranes, and these membranes are associated in former investigations. They thought that this is associated with anemia and was called the Plummer-Vinson type of membrane stenosis. Now we are more reluctant to this combination and think that they might be due to eosinophilic esophagitis, but this is not quite clear. What is clear is that we have membrane stenosis on the upper esophageal, at the level of the upper esophageal sphincter. Another important reason for that could be after radiation, but in this case it was de novo without any known other condition. And on the left side, you see such a membrane, a scarring stenosis of the pharyngoesophageal sphincter, and this is leading to a jet phenomenon. And on the right side, we see a membrane which doesn't cause too much an obstruction, but is only visible as a very tiny little indentation of the barium column. So this is a membrane stenosis of the pharyngoesophageal segment. So let's move on to the seventh functional unit, and this is the esophagus. So we would be interested what the audience may think about this patient with a severe solid food dysphagia. What is happening here? Any idea from the chat? This is not normal too. We show you now the normal esophagus. The normal esophagus is just clean after swallowing. This is in the prone position, and you see the compressed material running down and cleaning the esophagus completely. And in this case, what's happening here?
The question is there is a irritation due to dysregulation.
It is a kind of dysregulation, that's true. These are non-propulsive contractions. It means that the esophagus doesn't have a coordinated stripping wave, and, which is most important in this case, no correct opening of the lower esophageal sphincter. This is a kind of achalasia. Usually you will see achalasia as a dilation of the esophagus, but in this case, this is a severe motility disorder where the patient cannot swallow correctly and is presenting with a high-grade transport problem in the esophagus, and will have problems with fluids and solid boluses as well. So I think at this stage we are late in our webinar, and I would like to show you just where this app is coming from. This is from University Publisher 3.0, and this app is called the UP3 Coach, where we have 30 cases to explain swallowing. So at this moment, I would like to jump into the quiz mode. And this quiz, you can win book prizes. We would like you to read this little story. This is a 70-year-old lady, dysphagia for solids and fluids for over 20 years. No clinical evidence of aspiration, no global symptoms. She suffers from heartburn once a month, a little bit, while PPI medication is taking over years. In 2001, a motility disorder was detected by manometry and no pathologic refluxes by pH monitoring. A myopathy is known and causes some weakness of the extremities, but there are no substantial limitations. So in the video fluoroscopy, we saw a normal pharyngeal face, and a placebo tablet gets stuck in the upper esophagus. You see it here indicated with a red arrow. So this is a very classical disease which was not known 10 years ago, but now is entering our medical ambulances, and you should have an idea about it. Is there any idea? So we give you time. This is a benign disease and is causing problems of the esophagus by narrowing. And this disease has a name and is more and more common. Any kind of right observation in the chat will be counted. So it is not necessary to have the histological diagnosis, but good comments are accepted. And well, there are some comments, so we will give you time for this. The second case, all of you know bariatric surgery for severe adipositas, and there are different methods to do it. One of them is gastric banding, gastric bypass, but there is another one. You see the operation technique with the drawing up here, and this is the gastric sleeve resection. And this lady lost 21 kilos 5 months after bariatric surgery. A gastric sleeve resection was performed. She suffers from frequent regurgitation of solid food, and endoscopy was not possible in optimal quality. And the further workup was radiology. And this is the stomach. You see here with the arrow, the very interesting area. What has happened to this stomach? Are there any suggestions? This is a typical problem of this type of surgery, and is leading to big problems. I was testing that with a sandwich, and the sandwich was regurgitated about 10 minutes after eating the sandwich together with barium.
Some suggestions are coming in from the middle. So Be brave, audience.
So the first case was the tablet, the stenosis, and the somewhat small esophagus. In the second case, this pathological appearance of the stomach after an operation where a big part of the stomach was resected to decrease the space and to help weight loss in terms of a restrictive operation.
Today people are quite shy.
I know these are difficult cases, and we are expecting just some comments on them.
Yes, there is a problem.
Oh, it's no problem. It is not the correct answer necessary, just a good comment on that.
The question is coming, is the upper image the first one? Is it taken before the lower one or after?
The first image is after ingestion of barium alone, and the second one after ingestion of the sandwich. Okay. So, these two quiz cases, now we will solve the quiz, because the most important thing is to learn. The first is the now upcoming modern benign disease of the esophagus, is eosinophilic esophagitis. And this is an allergic associated inflammatory disease of the esophagus, most common in young males by presentation and diagnosis. And from 400 endoscopy, we may expect to have 1 or 2 of these, 1 or 2% of these patients, and from them, a small proportion will suffer from stenosis. And the famous Schatzki ring, as well as multiple benign stenosis in the esophagus can be found. And in this patient, it was an elder lady, because the disease is not maybe not elder than 15 years, and in the common clinical practice, it is getting more or less modern now, and you should take care for people who are presenting with solid foot dysphagia. This is the classical endoscopic appearance. This irregular network of an inflamed mucosa, and the histologic diagnosis is done by eosinophilic proof of more than 20 eosinophilics per high power field. We find multiple rings, smooth stenosis, and this is often missed by endoscopy at an early stage. The right upper image shows a tablet stuck in the esophagus. The second case is just a severe stenosis after bariatric surgery, and the interesting thing is that this group of patients after bariatric surgery often present with complicated symptoms, and it is very important at this point to see that the stomach is included into the upper GI tract, and behind the problem of the stomach can be the presentation of a patient with dysphagia. So a test meal is very helpful to evaluate these type of patients as well. So at this time, we are at the end of our webinar, and we are happy to invite you for our next webinar at the 18th of November. You can sign in on the webpage, and the next topic will be announced soon. So I thank again the team, Barbarin Kobo, Evelyn Simic and Alexander Hirsch, and the co-authors, Doris-Maria Denk and Martina Scharitzer.
Thank you very much.
Thank you.